You might think, why would you spend your whole life training to treat the eyelids? Well, there's lots of work to do on the eyelids. We have the most diverse range of surgeries that we do, including adults and kids. And we treat eyelids, tear duct problems, and things like when people get tumors on the surface of the eye and on the eyelids, which are fairly common in a high UV place like New Zealand. You might say then, why am I speaking at a glaucoma information evening? Well, fortunately and unfortunately, there's a lot of crossover between glaucoma and the patients I see because the treatments that glaucoma patients have to do create a lot of eye problems in my area. My background is similar to most other eye specialists. We train as general eye specialists, and then we do subspecialty training in a particular part of the eye, and we we can manage all the eye problems that people get, but we're really good at certain things. And so over time, people's practice molds to doing a few things really well rather than lots of things not so well. And I'm based in Auckland as well as Queenstown. So, what's the scale of the glaucoma problem when we talk about dry eyes and eyelid problems? Well, I just did a few rough calculations yesterday, and looking at the population above 60, out of those, if we assume that up to 10% can have glaucoma, up to 60,719 people could have glaucoma in New Zealand at this stage. There's good research to show that 50% of people who have glaucoma and are on glaucoma treatments have dry eye disease symptoms. So it's actually a pretty big problem. It's not small. And so you will probably have to come across this issue if you are on glaucoma treatment at some stage in your treatment cycle. Unfortunately, all the things we do to treat glaucoma make things worse that affect the comfort of the eye. So tear production tends to reduce. You get dry eye changes due to the glands that produce oil in the eye not working well, and the tears don't last very long. So your natural tear function is compromised. Sorry, just moving on. If we look at the treatment pathway for most people, although things are changing now with new treatment modalities, drops are still the mainstay for most people in New Zealand. And there's a variety of drops. Some of these generic names you'll recognize, but essentially they all work to help reduce intraocular pressure, which is the pressure that can damage the optic nerve, which connects the eye to the brain. And they all work in a variety of ways. However, they all unfortunately have surface symptoms and cause surface damage to the eye. And I'll go through that a bit later on. So why are these drops an issue? Well, first of all, the medications themselves have side effects. So for example, uh, it's not the other compounding things or the other preservatives. It's just the medicines themselves can have a negative effect on glands. They can cause scarring and inflammation, which I'll explain a bit later on, and they can affect how you perceive the surface of the eye. Now, unfortunately, in New Zealand, all the drops that we have publicly funded have preservatives in them, and preservatives themselves are known to have quite a bit of a negative effect on the surface of the eye, especially if you're compromising that with other medications. The third problem is you need these drops quite frequently, and many of our patients are applying these drops more than once a day. So there's a cumulative negative effect of having drops frequently. And with increasing frequency, you're likely to get increasing symptoms and changes. And then finally, as I'm sure some of you have experienced, people are on multiple treatments at the same time, and that means the effects of these various medications and preservatives add up. And so all of these work together to cause an issue with the ocular surface. So let's go through some of these issues one by one. So if we look at prostaglandins, these are by far the most common initial treatment for glaucoma management for people who have high pressure or where we're aiming to reduce the pressure. The side effects of this to the eye surface, irrespective of preservatives and other factors, are chronic redness. They cause a scarring of the oil glands in the eye, as well as the mucus-producing glands on the eye surface. That has a negative impact on the lubrication of the eye. We all have about 20 oil glands in each eyelid, and that helps to supplement the tear film with an oil layer, which helps to minimize evaporation. These drops tend to cause a dysfunction in those glands, make the oil a bit more static, and essentially compromises your natural tear film. This is one of the major contributors to the tear film evaporating a bit quicker than it should. Now, one of these agents, bimatoprost, has quite well-known and described severe side effects in and above of what I've just described. For example, although most prostaglandins cause eyelash changes, bimatoprost tends to cause them quite aggressively. You get more hair growth, so you get longer hairs, and the hairs become thicker. And they can also point in different directions, which means the hairs themselves can actually irritate the surface of the eye. And this is something we accept as a side effect, but can be an issue for the ocular surface if the hairs are going the wrong way. One thing that people have seen long term is that it can shrink the fat in the eye socket. As you can see in this photograph, this patient was using drops only in the left eye. So you can see the eye looks a bit more hollow, the eye looks a bit more red and inflamed, the eyelid looks a bit more droopy, and essentially because of loss of fat, the eye shape has changed completely. Now, we have actually started to use these side effects in other parts of medicine to our advantage. For example, in conditions like thyroid eye disease, which is totally unrelated to glaucoma, people get an expansion of the fat in their eye socket, and sometimes we put them on bimatoprost drops to help shrink the fat so that they can avoid surgery. The other thing is prostaglandins are now used in lash serums and quite commonly in cosmetic mascaras and things to help promote eyelash growth because people actually like having thicker eyelashes at times until it's a problem, unfortunately. So you just have to understand that, you can moderate some of these side effects, but for people who are on these drops lifelong, these side effects can be quite severe. The next category of drops is beta blockers, the most common of which you'll see called timolol. Now, timolol itself is generally well tolerated, but beta blockers as a whole category do cause some cumulative side effects that worsen dry eye. For example, they block the signals that control the lubrication of the eye. So your eye can't really feel when it needs to lubricate itself as well. So your feedback systems are disrupted. The second thing is it can affect the nerve signals within the eye. The eye is one of the most sensitive parts of the body. There's about 3,000 nerve endings per millimeter squared. And so you can imagine if you have a reduced sensation, the eye can't really feel when it needs to lubricate itself, and that impairs your eye surface healing. Independent of preservatives, timolol can still have these effects. So even if you get a preservative-free version, you may still suffer some of these effects on its own, purely based on the beta blocker nature of the medication. And then finally, it doesn't seem to be a major thing in clinical practice, but some people do report some transient redness or irritation. But we find for most people, this goes away with persistent use. The next very severe category are the alpha agonists, and the most common we know is brimonidine. Now, this is actually a really effective drug to reduce eye pressure, but unfortunately for most people, the compliance tends to be poor due to the side effects. We know that 25% of people who start this treatment get a transient redness, and this is one of the common complaints about it. But if you push on through that treatment period, generally this goes away for most people. Unfortunately, up to 15% of people can get an allergy type uh, syndrome, essentially, where the eye just cannot handle the medication well and forms a late stage allergy, which can even happen weeks or months after you start using it. Can cause chronic irritation, redness of the lining of the eye, as well as, as in this picture, a skin reaction, which can be quite severe. Therefore, we find that a few people can tolerate this really well, but a lot of people can't be on these drops lifelong because they drop out due to these side effects, which can happen anytime. And generally, people don't like when their eyes look angry and irritable, so that's another reason people don't like using these drops long term. Now, unfortunately, outside these various side effects of the medications themselves, I would say the main culprit for dry eye symptoms with glaucoma medication is the preservatives. The preservative that's in most of these drops that we use including other medications, not just glaucoma drops, is called benzalkonium chloride. It's very effective at getting rid of bugs, and it's essentially the same compound in wet and forget. Unfortunately, it's also toxic to the surface of the eye. So, although it's effective at doing what it needs to do and preventing infection from growing in these bottles of drops that you have to use for a long time, it itself can have a negative effect. And unfortunately, it's cumulative. That means the more you use it, the more likely you are to get these side effects. We tend to see scarring of the oil glands. We tend to see a roughening up of the surface of the eye. Like here, the cornea is meant to be nice and clear. You can see lots of this hazy kind of dye uptake. That means the surface cells of the cornea are not doing very well. That means some of them are not healthy. This causes a chronic dryness of the eye, which is really intolerable for some people. And unfortunately, in New Zealand, the preservative-free alternatives are not funded. So if you are getting severe eye symptoms, there's a financial cost to trying to change this and move on to other alternatives. And that is a big motivator or a big driver of what people choose because, this is a lifelong treatment plan for most people, and the financial impact can add up over time. So the next part of the talk really is, I've just been talking about dry eye for about 5 or 10 minutes. Why am I now starting to talk about watery eyes? Well, unfortunately, they're quite linked, and I'll show you why. This is really what happens. We You can't have one without the other, and this is a little bit of a difficult concept to understand, but we know that all these treatments create a poor ocular surface and dry eye. Unfortunately, over time, that leads to hypersensitivity of the nerves, and you get severe dry eye symptoms. The brain's got a good feedback system. The body's always trying to feel comfortable and get things right. So as soon as it feels a trigger, you'll get reflex tearing. So unfortunately, although your eyes are dry, you can suffer from watery eyes as a reflex as the brain is trying to fix the problem. This is the same feedback pathway that you get when you're trying to cut onions. Onions, when you break the cell membrane, a few chemicals join together and form a vapor. They hit your eye and they're really irritating. That's why you start flooding your tears straight away. So it's a reflex that you trigger, but unfortunately, in this case, it's from your chronic management of glaucoma. One of the other things I'll explain, which is an important factor and which is where, as an eyelid specialist, I get involved, is some of these things have long-term lid changes, which I will explain. These lid changes are quite severe in causing watery eyes. So many of my patients who have had glaucoma treatments over many years will end up coming to me when they have these lid changes. But that's often at the end of the cycle, it's not at the start. So what is this pathway? You don't really need to understand the full diagram here, but this is really just to show that you've got an input and an output, and the blue line is the input. The corneal nerves go down, they get irritated by having this chronic dry eye, they send a signal to the brainstem, and then it's got an outflow pathway through the facial nerve. Now, most of the time, you will have experienced this when you go out into the wind and you start blinking a lot. So you start triggering first a blink reflex. When your eye is irritated, your eye muscles activate to try and blink to get rid of whatever's in the way. If you get dust in your eye, anything irritable, you will want to get rid of it. There's also a separate branch of the facial nerve which controls the lacrimal gland, and that's a gland that sits inside the eye socket, just on the corner, and that floods the eye with lots of watery tears, which are high volume, and try to wash the whatever's irritating the eye away. Unfortunately, in this case, the trigger is dry eye and chronic damage. So it's not like one thing you can wash away. This is a pathway that gets chronically triggered, and people can suffer from chronic watery eyes. So what are the eyelid changes that contribute to watery eyes, irrespective of this reflex tearing? Well, there are really three things that we see commonly in clinical practice. The first one, which is often the easiest to treat, are these abnormal eyelashes, usually seen with prostaglandins. They kind of trigger abnormal hair growth, and sometimes the oil glands, which are adapted hair follicles, can switch backwards and go back to becoming a hair follicle. So where you'd normally have an oil gland, a hair might start growing, and because it's pointing towards the eye, it starts to scratch the eye, becomes really annoying. It's like having a bit of sand in your eye 24/7. Although it looks like a very minor thing, these patients are the most unhappy patients you'll ever see because with every blink, they're reminded of this problem. The good thing is we can treat this quite easily. Essentially, we can do a minor treatment in the clinic and kill those abnormal hair follicles straight away, and the success rates are very high. So, if diagnosed early, it's usually a non-event to get this sorted. The second thing that can happen with chronic use of eye drops tends to happen with people who have been on glaucoma medication for some time is scarring of the tear duct entrance. Where that arrow is pointing in the middle picture, there should be a tiny little hole that's like the gutter or the drain for the tears. And because the lower lid drains 90% of the tears, if the lower lid tear duct is closed up, you're going to have a dripping eye all the time. And it's a really annoying problem. It can be quite severe, especially with some of those drops that you have to use quite often because the preservatives add up and cause this cumulative damage. It's like having leaves blocking a gutter on the street. You know, the gutter might be fine. You might have a normal tear duct and it's not blocked. But if the tears can't get into it, it's kind of pointless. It doesn't work. So the tears just spill over onto people's cheeks. It's really frustrating to live with. The final thing is if the lids themselves go out of position. This is a patient who had that brimonidine related allergy response. You can see in the above picture, both eyes, the skin looks really scaly, really red, and the lids are being pulled out of place, and it looks really uncomfortable. Because the lids are out of place, the tears can't drain anywhere. So this is what causes watery eye. Fortunately, in this patient, just by changing over to another medication and treating this allergy type syndrome, the skin softened up over time and the lids went back into position. So this was a reversible type of eyelid change. Sometimes it's irreversible if there's lots of long-term scarring, or patients have other factors like sun damage and other things which on their own can cause lid problems, and this may need surgery to fix. One of the other factors that causes this to be worse in glaucoma patients is that whenever you put in the drops, you tend to stretch your eyelid down. And that's often how people are shown to put the drops in. Well, if you imagine 10, 15, 20 years of stretching your eyelid, it's going to become loose and saggy over time. And unfortunately, it accelerates that natural aging process. So if you've been on drops for a long time, some proportion of people will get this eyelid, what we call malposition, or the eyelid being droopy, just as a factor of being on glaucoma medication, even if the glaucoma medication itself did not cause the problem, just putting them in. The final common thing we see is a droopy eyelid, and this is something that can only really be fixed surgically. This is a cumulative change due to scarring of the lining of the eye. It tends to make the muscle that lifts the eye a bit weaker and the connection between the muscle and the eyelid weaker. So you have to surgically lift it to make this work, but fortunately the options are quite good. I would say our success rates are around 95% with a fairly straightforward surgery. Another factor, once again, is putting in the drops. Some people pull on their upper eyelid to put the drops in. They can get a higher chance of getting this droopy upper eyelid. So the important part really of this talk is what can you do about it? Let's say you face these problems. What are your options to treat some of these different symptoms, whether it's dry or wet? Well, you can be quite proactive. I mean, you've got a balance here at the end of the day. You've got to treat a condition that's chronic, but you also have to treat the side effects that come with it. So ideally, first of all, you would try conservative things. You try to figure out if it's a particular drop that's causing it, and then work with your glaucoma practitioner to change. If it's the preservative, you might try to figure that out by using a preservative-free version for a short time. Because if it's the medicine and not the preservative, then you don't need to keep buying the preservative-free version. But it takes a bit of investigation and trial and error to work this out. For some people who only have mild symptoms, all they need to do is lubricants for symptom relief. Just supplement your natural tears, which have been compromised by these medications. And for a lot of patients, this is all that they need. But unfortunately, due to the cumulative nature of these symptoms, that might only last you a few years, and then you may have to escalate the treatment. And then finally, because we know most of these drops cause a problem with the glands that produce oil in the eye, if we get those working better, you will have better tear film quality. And you can do warm compresses every day as a preventative thing, as well as some eyelid massage to stimulate the natural function of the eye. And I think that's an easy thing. It's low risk. It generally works, and it will help most people. And so this is something you can discuss with your glaucoma practitioner. Now, unfortunately, for some people, this is not enough. And the data shows that out of all the patients that have dry eye or watery eye symptoms, 30% are mild, 30% are moderate, and 30% are severe. So out of all the people, which is up to half of glaucoma patients who are going to have problems, 30% of those will have really severe symptoms that need active management. So what's the next step? Let's say you've tried everything at home, you're on the best drops you can get, and still you're getting symptoms. Well, I would say the next step is a dry eye clinic assessment. There are plenty of them around the country, which are specific dry eye services. Some of them are optometrist led and some of them are ophthalmologist led. For example, we have one in our practice, and the reason it came about is because nobody was really doing uh, evidence-based therapy for dry eye things, and we kind of did it as a necessity for our patients. But we've found that generally the uptake is very good, and our feedback rate is about 95 to 98%. So 95 to 98% of people that come for an initial assessment and have some treatments with us will keep coming back for repeat treatments. So we find that it's a high yield or a high success type of service. And what does this service involve? Well, firstly, it's all about assessment. If you look at this picture on the top right, this is an infrared image. It's what we call gland imaging. So we can actually measure how scarred or how damaged your glands are. If you look at the picture on the left, you can see these little white streaks. Those are the little glands that produce oil. And if they're all present, means there's a good chance we can turn their function around with the treatments that we offer. If it's too late, if we see no glands, well, some of these treatments aren't going to work. So we need to really know what the lay of the land is before we attempt treatments. We don't like to just hope and pray for treatments. We like to do things that are likely to work. So actually, assessment is, I think, one of the most important parts. We can also objectively measure your tear film quality, how much oil you have in your tear film, whether your tear film is good or bad, and how quickly it dries up. So these are all important things to know because they give us a good starting point or a baseline to see if our treatments are going to be effective. The next level up from just heat and massage at home is a treatment called LipiFlow. This is on the bottom left. This is a little machine that attaches to the eye and heats the eyelid up to 40 degrees Celsius, which is the temperature that studies show liquefies the oil. And then it also does its own massage. So it's almost like a deep clean version of what you can do at home because you'll never be able to do it as good as what this machine can do. But it's only going to work if the imaging shows that you have some glands that can be rescued. Finally, the last step is called intense pulse light or IPL. This was initially designed as a skin treatment for people with other skin inflammatory disorders, but we found that when they were having their skin treatments, their eyelids also improved. So now we have eyelid specific versions, like on the bottom right. This is called OptiLight. They shine a light through the skin, not into the eye, but into the skin, and the light can penetrate through the skin into the glands, heat up the oil, as well as it has a long-term anti-inflammatory effect. So we find that effectiveness is about 90%. 90% of patients who have IPL will notice a symptomatic improvement, plus we can measure an improvement on these baseline tests. What is the problem with all this? The problem is you have to have these treatments done to you. You can't do this at home. So it is all based on your accessibility. Can you get to a dry eye clinic? You have to keep coming back, so it costs money. And generally, you start, with a loading treatment. You might do 3 or 4 treatments every 2 or 3 weeks, followed by maintenance every 3 to 6 months based on your response. If we find no response on measurement, then we don't keep doing it. But for the 90% that it works, it's very effective, and the cost is approximately 250 to 300 per treatment. So you have to think, it's an ongoing cost that will also shape people's behavior. Some people may just want to put up with their dry eye. Now, surgery-wise, well, at the end of the day, I'm a surgeon, so some of these things I have to fix with surgery. I can't push them out. So if it's an anatomical issue, like let's say the first problem we have is abnormal hairs, we can sort this out in the clinic. It's a 5-minute treatment. We put in some local anesthetic, and any abnormal hairs we can kill with a fine metal probe, which is a painless treatment that takes about 30 seconds per hair. The success rate is about 80% per treatment. So some people who've got very stubborn hairs may need 2 or 3 treatments, but generally one treatment will fix the problem. The second problem is that narrow tear duct problem. That can't be fixed with medication or stopping medication. Once it's narrow, it's narrow. You need to open it up. And we can do a minor procedure called a punctoplasty. Takes about 5 minutes, and we enlarge that tear duct entrance permanently. The good thing is it's minor, and the success rate's once again about 90%. So 90% of people who have a narrow tear duct entrance, once we open it up, it will last them their whole life generally. So it's a high success rate and low risk surgery. The last step is really when things are severe. If the eyelid has dropped, it's not improving with changing drops, and people are symptomatic enough to want surgery, we have to do eyelid surgery. There are a variety of different ways to reposition an eyelid. I could go on for about 5 hours on how we do that, but essentially it's about a 30 to 45 minute surgery per eye. Can be done under local anesthetic or for people who are a bit squeamish under IV sedation, so you don't remember anything. But generally, these are also high success rate operations, about 85 to 90% success rate long term. So they work pretty well. So looking forward from now, looking into the future, is this going to be an ongoing issue? Well, we know that trends are changing now. There's good evidence now that non-invasive treatments such as laser and minimally invasive glaucoma surgery are becoming commonplace. And so this whole treatment algorithm of drops first and then other things later has quite radically changed in the last 5 years due to quite a lot of international research on first-line treatment. So hopefully we will see that these problems get less and less as we try lasers and other more permanent treatments to avoid having to use drops so much. Even if we reduce the drop burden for patients, you will still see some benefit because most of these side effects are cumulative. So if we can even reduce people's drops, it can be quite an effective strategy to minimize these long-term issues. We have also have better diagnosis, so we're picking up glaucoma a lot earlier. It's very, very rare to see vision loss from glaucoma now in someone's lifetime if it's appropriately managed. And then, we have adjuncts like these little stents called eye stents. A lot of the times when people have routine surgery like cataract, we can put these in to help reduce the eye pressure, and this can have a long-term effect and reduce the drop use, and that's well proven now. The problem is a lot of people have glaucoma and our population's aging. So there's a wave of patients who are going to need lifelong care, and you can't do these treatments for everyone. Not everyone can access a laser. Not everyone can even get to an ophthalmologist. So in many places which access is difficult, a lot of the management will be in community with your optometrist, but with ophthalmology guidance sometimes or second opinions. So we still will face this issue, I think, but hopefully in a reducing manner. Another interesting thing is, can we reduce the need for drops long term? Lasers and things you can do to someone. Can we actually put devices in the eye that help? It's quite interesting to see that prostaglandins are coming back after having had a bit of a bad rap for a while because of the side effects. There are now lenses that can be put in the eye with little prostaglandin buffers, so the medicine can work from the inside and last 3 to 4 years, and might mean you don't need drops for at least 3 to 4 years after routine cataract surgery. Our clinic, Auckland Eye, is quite big on clinical research, and one of our doctors has been one of the leaders in the study, and we're currently in phase 2 of this trial, and it'll be interesting to see what the long-term outcomes are. It may mean that we defer all these side effects, and you won't get the nasty side effects of prostaglandins, but get the important pressure-lowering benefits and buy some time, essentially. So hopefully this is another way that we can reduce the dry eye and watery eye problems that glaucoma patients get quite often. Now, the final slide. We need to look at what this means for you as a patient. So yes, we've talked about dry eyes and watery eyes and what we can do to fix it, but there are some long-term effects that you need to be aware of because you will have other eye procedures where this makes a difference. For example, if you have a poor tear film or dry eyes, if you end up getting cataracts, which is a guarantee for every human being at some stage, if your dry eye is not managed well, you will get a bad result. And the reason is The measurements that we take rely on good lubrication, repeatable measurements, and accuracy. If you have dry eyes, everything is variable and we don't get good measurements and we end up getting not as accurate results. So being proactive about these sorts of problems can have good downstream effects for other things you may have to experience in your lifetime. Same thing with eyelid issues. I get a lot of patients from my glaucoma colleagues who have got eyelid issues. If we did cataract surgery on those patients with an eyelid in the wrong place, they would be at much higher risk of infection, and the infection can be devastating. So you've kind of, by not
Mm.
being proactive, got a much worse outcome from something that we would normally think is routine. It does also involve a collaboration between your practitioner and yourself. So if you are symptomatic, please discuss with your glaucoma practitioner. They will have a pathway to help try and find out what's going on, or at least help you manage this to work out whether you'd be a good candidate for non-drop treatments or changes to your medication are required. But if they don't know that you're suffering,
Mm.
no one can help you. So I think it's important to say if something's a problem, work with your glaucoma practitioner, whether it's an optometrist or an ophthalmologist, to help improve your symptoms. And the final step really is we can't ignore the glaucoma. That's why you're in this boat. This is a lifelong progressive condition, so we can't just stop every drop and fix your dry eye if you're going to get permanent vision loss long term. So any changes, any modifications of treatment need to be within safe parameters so we don't lose control of the glaucoma. So don't stop your drops if you're symptomatic unless it's under some sort of monitoring or guidance. I think that's really important because we do get a lot of patients who stop drops like brimonidine, etc., which makes your eye look horrible, but it means your glaucoma then is out of control. And thank you for your attention. I hope that's been useful. Happy to take questions, comments, and yeah, that's my little overview on dry eye and watery eye for glaucoma patients.